Good morning, everybody. My name is Claire Magner. I'm a lecturer in children's nursing in the School of Nursing, Midwifery and Health Systems in UCD. Firstly, I would like to offer my condolences to those who have lost family, friends or colleagues to COVID-19, either directly or indirectly. It certainly has been a year like no other. And just by way of some housekeeping to mention now, all attendees have been placed on mute. If you have questions during the presentation, if you can enter a window only, so the section, just simply move your cursor to the bottom of your live screen video box and locate the Q&A icon, then click and type away. So please don't enter any questions into the chat box. This webinar is being recorded. You will have access to this recording within about 5 days on the UCD Nursing and Midwifery YouTube channel. It's important also to say that this symposium has been approved for 3.5 CPD credits from the College of Psychiatrists of Ireland. We have a Twitter hashtag, that's hashtag COVID-19FLW. So please do include that in any tweets. And I hope you do send some tweets around. We expect that the symposium will run until just before 2 p.m. We have some wellbeing supports on the symposium web page that have been provided by Ono Fuelon from IBEC, from Mona Baker, who is on the panel here, from Ciara Latimer from the HSE in relation to the National Psychosocial Response Framework. So I would like to hand you over now to Professor Fiona Timmins, the Dean and Head of School of Nursing, Midwifery and Health Systems here in UCD, who will deliver the welcome address.
Good morning, everyone, and thank you, Claire. Distinguished guests, Professor, Dean, and all of you here today. I'm delighted to see so many people at this event. I'd firstly like to thank Claire and Justin and colleagues in UCD for having the foresight to prepare this event and putting the work into the day. It's incredible. I don't think there's ever been a moment that I've ever felt so privileged and so humbled to be part of the nursing profession and indeed the wider health profession. I mean, incredibly, as a third generation nurse, to be part of the world crisis that we're in, to see such strength and commitment and delivery like no other. It's an incredible time. And I want to thank everybody that's involved in the health services for your commitment, for your generosity, for your kindness, your feeling, your support of us as a humanity. Of course, we know this has been unprecedented. None of us were prepared for this. And it really shows the strength in our togetherness at this particular time. The day is pivotal. We've got some incredible speakers, and I'd like to welcome our speakers, Professor Neil Greenberg from King's College London. He's going to discuss aspects of moral injury and mental health. And these things are so important for our staff and our people that use our services. We're going to cover a range of very important topics that I hope will be of interest to the audience, and I hope that you will enjoy and gain great benefit from this day. I would like to extend my thanks to not only all of the participants today, but all of you in healthcare organisations, both within Ireland and across the world, for your commitment, your generosity, and my heart goes out to each and every one of you, as this is a challenging time, a struggling time, and I know not only within that commitment to the organisations is it quite challenging, but in your own personal and family life. So I thank you. I ask you to keep strong, and I hope that this day will empower and enable you to open conversations and to continue conversations as joined up healthcare workers working towards enabling us to have a better future. I thank you.
Thank you for that, Fiona, that wonderful welcome. And now it's my privilege to introduce our keynote speaker, Professor Neil Greenberg. I unfortunately had to shorten the bio, which broke my heart, because it would take an average person quite a few lifetimes to achieve all that you have done. And it is so wonderful to welcome you here today to join us. Professor Greenberg is a consultant occupational and forensic psychiatrist who served in the United Kingdom Armed Forces for more than 23 years and has deployed as a psychiatrist and researcher to a number of hostile environments, including Afghanistan and Iraq. You completed a master's degree in clinical psychiatry, a doctorate in mental health, and you are a fellow of the Royal College of Psychiatrists. Since 1997, you've been at the forefront of developing peer-led traumatic stress support packages, which are now used by a wide variety of organisations. You provided psychological input for Foreign Office personnel after the events of September the 11th in 2001, and in Bali after 12th of October bombings in 2002. In 2008, you were awarded the Gilbert Blaine Medal by the Royal Navy for your work in supporting the health of naval personnel through your research work. You've published more than 200 scientific papers, book chapters, and you've presented to national and international audiences on matters concerning the psychological health of the UK Armed Forces, organisational management of traumatic stress and occupational mental health. So welcome, Professor Greenberg, and I'm looking forward to hear you speak to us today about moral injury, mental health and healthcare staff.
Thank you very much indeed for inviting me to speak. Hopefully you'll be able to see my screen. It's always very painful actually sort of listening to your own bio, isn't it? It's like looking in the mirror, or maybe that's just me talking. So I'm going to cover topics related to sort of mental health and moral injury, and obviously particularly focus on what's been going on over the last year across the world. You've already heard my bio. You don't really need to hear that again. I think the key thing in terms of today's talk is twofold. One is that myself and my research team at King's College London have been doing an awful lot of work looking from an academic point of view at the mental health of healthcare workers, which I'll present a little bit of data on as we go through. And the other thing to say is that in terms of NHS England, our sort of overriding sort of headquarters, if you call it that, for our health service, that I've been heavily involved in helping them try and sort of shape the sort of support that they have been putting in place. And indeed, this sort of support that hopefully all of us will begin to think about over the next few months, which might be sort of labelled as recovery or rebuilding or whatever the right evolutionary term is. I'm happy to share my slides, and if you're interested in the academic papers, the vast majority of them are freely downloadable from these different places. We have a health protection research unit at King's College London that's actually been going for more than 6 years now, and we do pandemics and we do disasters, and we a year and a half ago we were busy, but as you can imagine over the last year things have been pretty hectic, but also pretty good news from an academic point of view anyway, despite the horrors that are going on. So over the last year or so, there's no doubt that healthcare workers have been exposed to a wide range of different stresses. So there's been trauma, and we all know that trauma doesn't just come in the form of unfortunately people dying, but also in terms of difficulties that we see in patients who survive as well. Workload and shift patterns have been important. There was early data actually from China which showed that actually nurses who were working shorter shifts reported much better health than nurses who were working longer shifts, the 12-hour shifts. But of course that's had to be balanced with the fact is there's been an inordinate amount of patients coming through, so that it's getting the balance right, which is just difficult, I think, for operational managers to think about. Whilst this has all been going on, obviously home life's been different for many people. We know about the lockdowns. We know that actually some people have suffered bereavements, unfortunately. And of course, even other stresses, such as people losing their jobs and difficulties with schooling and children, they all impact as well. I think it's worth saying, certainly the UK data that we have shows that the biggest demographic at risk in the community are young people between the ages of 18 and 35, females, and people who have dependent children. I think if you were looking certainly across, who makes up a lot of the healthcare workforce, actually that demographic is very well represented. And therefore, even not thinking outside of what happens at work, they're a group who's at risk. And then there's this concept of what's called moral injury, which has become certainly far more talked about over the last year. The concept of moral injury started sort of from the military, and probably around the time of the Vietnam War was the first time it was talked about in great detail. But actually, if you go back right to the time of the ancient Greeks, there were plenty of writings in books that I must admit I don't read, and Homer's The Odyssey and the like, which talk about the existential challenges of what should be done when there's no right answer. And that's the crux of what a moral injury is that I did my best, but actually that still was not good enough. And it describes the the distress, the profound distress that occurs when your moral or ethical code has been broken. And at the bottom here, I've tried to represent the fact that moral injury occurs along a spectrum. So hopefully most of us are well most of the time, but we all get into situations where we experience what has been termed moral distress. Did I do the right thing? Should I have done more? You know, have I been let down? And that moral distress in most cases resolves, but in some cases it begins to become embedded. And we probably have all had experiences at times where we go over and over situations wondering about what the right thing to have done or what the right thing should have been. And then occasionally, unfortunately, people who suffer moral injuries develop illnesses. So just worth pointing out that moral injury itself is not a mental health problem in terms of a diagnosis. If you look in the Diagnostic and Statistical Manual Volume 5 or the ICD or whatever diagnostic textbook, you won't find moral injury as a diagnosis. But as I'll mention in a bit, it's important because it definitely is associated with diagnoses, with illness. So moral injury can occur in one of three main ways. First of all, it's through acts of commission, things that I did that or other people did that shouldn't have happened. And people may end up thinking, you know, if I told people about what I did, then they're going to think I'm a monster. As an example, one of the situations, one of the teams that I've been supporting, there was a young nurse, and he was on working in intensive care, and it was very busy. They were saving lives, and he ended up giving a medication through the wrong route. You know, instead of giving it intramuscularly, you know, he ended up giving it intravenously, and that led to a very bad outcome. Was it his fault? Well, you know, we can debate that in a busy environment when he didn't know quite what he was doing. Was he well supervised? And the fact is, that situation should never have occurred. But the pandemic has been unprecedented, and therefore it did. And these sorts of situations cause difficulties for everybody, including the patient, but the person and their supervisor as well. There's also can occur through acts of omission. You know, what didn't I do? The supervisor who wasn't there at the bedside to help this particular nurse because they were doing something else, was that the right decision? And then there was betrayal, often by a higher authority. You know, I was let down by people that I thought I could depend upon, that I thought I could trust. And certainly early on in the pandemic, the whole PPE difficulty was a good example of this, because if you were a supervisor, you wouldn't want to send your staff into situations where they might be damaged or injured. But at the same time, if you didn't go into those situations, then patients may die. And so there are no right answers. I don't know if any of you have done your resuscitation training lately, you know, but the recent updates on resuscitation training say that, you know, we should not be giving rescue breaths to people who collapse. Now, is that the right thing? You know, I mean, obviously it is from a COVID point of view, and I'm not a resuscitation expert, but that leads you into difficult situations where you may feel you're not doing the right thing, and you may be letting people down. When you compare post-traumatic stress disorder and moral injury, you see that actually there are lots and lots of similarities. And I'm not going to go through this whole particular chart, but I want to point out just a couple of things. With PTSD, the predominant emotions are ones of fear, horror, and helplessness. Whereas with moral injury, guilt, shame, and anger tend to be the predominant emotions. And what you tend to lose in classic PTSD is that feeling of safety. The world is no longer a safe place. But with moral injury, it's a loss of trust, and that trust may be in others, or it may be in yourself. We did a review on looking about moral injury and mental health, and we tried to be looking at it in an occupational setting, which we published in the BJ Psych. And overall, what we find is that moral injury is associated with post-traumatic stress disorder, with depression, and with suicidality. Now it's important to say, certainly UK data, that the rates of suicide in the general population and in specific occupational groups has not gone up. You know, we have no data to suggest there's some sort of epidemic of suicide, but certainly the thoughts of self-harm and the thoughts of not wanting to be around, they have gone up. So I think this is something certainly to watch for the future. But it's also worth saying that within this data, most of it comes from military samples. And of course, healthcare professionals and military, you know, they share some similarities, but they tend to have very different mindsets about the rights and wrongs of the world. And I won't go into this in detail, but if you're interested in the paper, this was published in the British Medical Journal in March, and what we last year. And what we tried to do is to look at what happens in the military and to try and give some examples of similar situations that might happen in healthcare settings. And I think particularly relevant to the rebuilding, to the resetting, to the recovery phase is that military personnel who come back from having done 6 months or longer in a really challenging environment, doing things that were difficult to do at the time. When they come home, that's when they begin perhaps to think about, what was it that I'd done? And certainly the period that hopefully we're going into where things begin to get better, there will probably be some soul searching out there, wondering about whether the right decisions were made at the time the situations happened. So what do we know about healthcare workers generally in terms of dealing with infectious disease outbreaks? Well, there is emerging data, and I'll show you some of it, about what's happening right now. But of course, we can't do long-term follow-ups because it hasn't been long-term since the pandemic is over. And in fact, the pandemic is clearly not over. But studies looking at previous pandemics and epidemic situations have been done, and they have been reviewed. And a review published in May last year, again in the British Medical Journal, showed that if you had a high exposure to direct frontline work, you were over 1.5 times more likely to experience symptoms of either PTSD or psychological distress. So I'm not saying it's only frontline staff, because it's not, but we do have to acknowledge that the ones who are nearer the front, who are doing most of the direct caring, are going to be more at risk. These are the risk factors for feeling that you are more at risk. And I point out again, it's the younger and more junior staff who are most at risk. And particularly, I think, where staff have been redeployed into areas where they're not normally used to working. So if you're a surgical outpatients nurse and you get redeployed into work in intensive care, that presents a challenge. Also, in terms of people with dependent children, that probably also means also dependent carers, if you're caring for other people. If you've had to isolate or quarantine because of the infection, we produced a paper published in the Lancet last February, March, which actually is the most highly cited paper we've ever had. It's had over 2,000 citations in a year, which is unheard of. But it was on the psychological impact of quarantine, so you can understand why it was of interest. And what we showed in that is that healthcare workers who have to isolate are disproportionately affected by quarantine. They feel that they let their colleagues down, and also they let their patients down when they can't go in. And we know that healthcare professionals, even at the best of time, aren't particularly good at taking time off. A lack of practical support, and also feelings of stigma. But the positive things here is that good communication, the right equipment, the right sort of rotas, and good support all had a protective impact. And what I'm hopefully going to do in just a minute is to cover some of the things that you can do to put in that practical support in place. The two big studies we've got running through King's College London at the moment is looking at healthcare staff. One's called NHS Check, which has got about 27,000 people in it now across 18 healthcare trusts. And the other one is an ICU specific study looking just at intensive care workers, for obvious reasons. So we use this slide here, shows just the PTSD measure. And I'm going to show you go through the actual numbers in a second. But it's important to remember that any survey you see reported in the news or in scientific journals, any self-report survey is only an estimate. Self-report surveys do not make diagnoses. So although we're going to show you very high figures, what I don't want you to think is the world is falling apart. But what I do want you to take away is actually the levels of trauma-related distress out there are really high. So across the NHS as a whole in England, we know that, that about 25% of staff are reporting symptoms that are suggestive of post-traumatic stress disorder. This is between April and June last year, so things will have changed a bit. It's higher in nurses than it is in doctors, and we find that consistently throughout our data. And intensive care staff, the rates are even higher, nearly 45%. So what does that mean? Well, as I say, it doesn't mean that 45% of ICU staff are going to have PTSD. But it does mean that a significant proportion will. And it does also mean that actually they're likely to be sufficiently symptomatic that they're going to have difficulty doing their job well. And of course, it goes without saying that if you have a unit that's used to dealing with 20 people, but you've got 50 people in, and you've got lots of new staff who aren't sure what they're doing, the chance of getting the same high quality outcomes as when you're just at your normal 80–90% are very different. And technically, this is called presenteeism. And presenteeism is being at work in body, but not being there in mind or spirit. And we know that across industries generally, not just healthcare settings, that presenteeism is a huge problem, and it costs far more to industry than absenteeism, which is not being at work. And in safety critical roles, this is particularly important. This is looking particularly at moral injury, and what we had in our big studies is we have a measure of potentially morally injurious events. So asking healthcare workers about those really difficult decisions and situations. And what we're able to do is to split moral injury events into low, moderate, and high exposure. And then we've got general mental health, we've got depression, anxiety, and we've got PTSD. And you can see those who have the highest levels of moral injury have substantially increased symptoms of all those different sorts of mental health disorders. So what this slide shows is moral injury is absolutely an important topic when you're looking at staff mental health, because it impacts upon it. So what can you do to try and make a difference? Well, before staff go into these difficult roles, I appreciate they're doing them now, there are things you can do to prepare people properly. People need to have the right information about the sort of situations they're going to get into. So what we don't want to say is, please come and save lives, because it's really important by itself. What we want to say is, actually, we need you to do this job. We need you to come into intensive care. We need you to work on the respiratory wards, but it's going to be hot and sweaty. It's going to be hard to communicate. And despite your best efforts, people are going to die. Now, that doesn't sound like a very good advert, I give you that. But actually, once you give people the right information, they can begin to get their head around it. What you don't want is for the first time for them to realize the enormity of the situation is to be at the bedside and be in the middle of it. It also allows people to decide whether they're ready to do that role. Because actually, if I've got relatives who are living in my house with me, and actually I'm afraid of taking the virus home and causing them to become ill, am I really in the right place? If I've not dealt well with trauma in the past, is it really the right situation for me? Psychological PPE as a term that's often been used, which is talking about how do you prepare people well for the tasks ahead. And probably one way that we think is probably the best way of doing this is to develop something called a wellness recovery action plan, which is basically a simple way of trying to think about the things that you normally do that keep you psychologically healthy. So it might be the music you listen to, the place that you go when you go for your daily walk, the people that you would speak to or connect with that keep you healthy. So you make the plan before you become distressed, so that when you are distressed, you can turn back to that plan and do one of those things. And then lastly, but really importantly, is about training people well to do their role. Really good evidence from lots of different settings that people who feel more competent and capable of doing their actual day-to-day tasks are less likely to suffer with psychological difficulties. One thing you won't see there is the use of psychological health screening. So what we know is unfortunately, although it's a nice idea, the making attempts to try and spot who might have problems when they go into a particular challenging role by using psychometric tests or psychologists to speak with people, it doesn't work. And this is a good study. There's lots of them, but this one came out last year. It used a very comprehensive assessment tool called the MMPI, which has got over 300 questions in it. It was used with police recruits in Australia and New South Wales, and they gave this particular test when people joined the police, and then they were trying to see, could they predict what would happen over the next 7 years from a psychological health outcome, and they found it predicted absolutely nothing. So don't be relying on, we'll screen our staff to make sure that they're tough, because it doesn't work, and it's also discriminatory because you're going to exclude people who could do the job perfectly well, but actually, your tests inaccurately decide that they can't. What about when you're in the middle of doing it, as many of us are right now? Well, we know there's a very good evidence that social support works and is helpful and is protective of mental health. But the question is, how do you make social support happen? So one of the things that you can do, rather than just say speak to your colleagues, is you can buddy people up. So on a particular shift, you can say, right, Sandra, Peter, what I want you to do on this shift is do all your work, please do. But every hour, I want you to check in with each other to see how you're doing and to have a discussion. And if there's problems, sort it out. And if you can't sort it out, come and see me, the supervisor, that is. So actually try and make social support part of one's duties rather than just something that happens when people connect. The most important part of social support within a team, though, is the relationship between the team member and their immediate supervisor. And there is a whole wealth of evidence out there showing that actually, if you have a supervisor who's capable of speaking to you about well-being and who you think is looking out for your well-being needs, actually the chance of you becoming unwell is reduced dramatically. Great study done again in Australia with firefighters, showing that training up supervisors to have psychologically savvy conversations led to a 90% reduction in sickness absence. When we look at our military data, we find that troops who think their immediate supervisor is looking out for them and is leading them properly from a welfare point of view have 1/10 of the rate of mental ill health for troops who don't. So actually the relationship between the supervisor and the employee or the staff member is critical. And what we know is the most important thing is that supervisors feel confident to have these psychologically savvy conversations. So what we don't want is, how are you doing, Neil? Oh, I'm fine. Oh, that's great, because that's not a proper conversation. And we know that people won't be open and honest. And you should do them as and when you need them, and also at the end of a shift. So because of this data, because we know that the supervisor's ability to have these well-being conversations is really vital, we developed this package called React, which was a short active listening skills package, which is designed to increase supervisors' confidence in speaking to their staff about well-being. And React stands for recognize, engage, actively listen, check risk, and talk about a specific plan. We delivered these through Zoom over a 1-hour package. We gave a short didactic talking package. We gave a little demonstration, and we gave people a template, and then we got them going into breakout rooms and practicing doing this. And they in teams of up to 10, sort of with 2 in each of the breakout rooms. And then the instructor went in and checked how people are doing. So we did that. We rolled out over 2,000 of those people trained as a pilot. And what we found overall, the pilots, not all 2,000, is that we measured before they did that React training, over half of them did not feel confident to support their colleagues. 1 month afterwards, 85% felt that they were confident in having those conversations, and indeed were having those conversations. This paper's just been accepted, and occupational medicine should be out shortly. So this is a bite-sized intervention which is aiming to improve the confidence of managers to speak about mental health, and that should lead to positive outcomes in the team's mental health. Another thing that helps is peer support, and we did what's called a Delphi study some years ago. A Delphi study is where you have people who are experts agree on consensus statements, and what we think peer supporters should be doing is listening to each other. They should provide very basic, simple interventions, problem solving, identify people who need help, and then get those people to go and get help, because unfortunately we know that many people who have mental health difficulties don't seek any help at all. One way this is done, it can be done, is through a program called TRIM, Trauma Risk Management. We developed this in the British military in the late 1990s, and our team at King's College London has done about 13 academic studies into TRIM. TRIM is not penicillin for trauma. It doesn't prevent people becoming unwell. But what we show overall is it's acceptable, it's credible, it helps with help seeking, and it appears to be associated with less sickness absence over time. And this is one way. TRIM is not the only peer support system around. There's plenty of other ones that might be used. But what we show here is that a good peer support program can make a big difference to staff mental health. But what we shouldn't be doing is psychological debriefing. And the idea here is what we don't want is lots of people like me, mental health professionals, kind of coming in to worry frontline staff. So there is a role for people like me, giving advice, supporting managers doing their job well is absolutely our role. But what we shouldn't be doing is coming in and giving everyone sort of trauma counselling or psychological debriefing to make them better. And the reason that our NICE, our National Institute for Health and Care Excellence, says don't do it isn't just it doesn't work, it's because actually it does harm. And so the studies that are out there have looked at comparison groups of people who received this sort of psychological debriefing versus people who were left alone or people who had a neutral intervention, and the people who are left alone or neutral intervention do better. So this is something we should not be doing. Instead, what NICE say is you should be keeping an eye on people, checking in with them, and then if they've got mental health problems, they should be getting evidence-based treatments, because there are some really good talking treatments out there that will get people well again. And then another thing that can be done in the workplace is to make sure that supervisors have an opportunity to properly support their staff if they do become distressed. And this approach, which is called the PIES approach, is shown to make a big difference. So the PIES approach, I'll run through them in just a second what they mean, but the attempt here is to try and nip things in the bud. And a good study done in the Israeli military in the 1980s They were involved in the Lebanon War. They had a lot of stress casualties, unfortunately, and they put in place these PIES principles. They followed them up for 20 years. You don't get many 20-year follow-up studies. And they found the more the PIES principles put in place at the time that someone was distressed, the better they were 20 years later on. So P stands for proximity. And that basically means that if you've got someone who's got a difficulty, don't say, go home, come back when you're ready. Instead, what we're looking at is saying, how do we support you better at work, either virtually, remotely, depending on what you're doing, or practically, and how do we temporarily reduce your duties a little to make sure that you've got an opportunity to recover? So I worked at the London Nightingale Hospital for the 2 months it was open last year, and what we're able to do there is staff who were on the shop floor providing care, if they became distressed, we could move them to the don and doffing stations, helping with PPE. So it was an important task. They were helping colleagues, but it gave them some respite from how the difficult task of being at the bedside. And that makes them more likely to feel that they're doing something useful, they get support, and then when they're ready, they go back in to do their main job. Immediacy says that when someone's got a problem, don't just say, oh, well, if you want to carry on, that's fine. Try and nip things in the bud. Try and stop things becoming a crisis, which is when they do present. So try and get in there early, have those psychologically savvy conversations, use your peer support. Expectancy says when you're in the middle of a pandemic, it's perfectly understandable that you're going to have some symptoms. You may not be sleeping great. You may be a bit more, have a bit more difficulty concentrating. If it's not impairing you, it's not an illness. So we shouldn't say, oh, this is terrible if you've got any symptoms. What we should have, and what the evidence shows us, is the expectation is that when things do get better, so do most of the symptoms. But the other side of expectancy is that if you're not going to get better, we're going to make sure you get the right help. And the last principle is simple things make a big difference. And so if you've got someone who's doing a particular task that they're not sure what they're doing, or they're not using a piece of equipment and that's worrying them because they don't know they're doing it right, the intervention is not mental health care. The intervention is supervision and mentoring from someone who can help them, because that's what makes a substantial difference. And then we come to recovery or rebuilding, which is the chance to hopefully where we're all going to be soon, where we're beginning to get back to some sense of normality. And so what can you do to try and increase the chance that people will have a good longer term outcome? And it's really important to say here, I think, that if you look at traumatic situations generally, you look at how people were beforehand, the situation itself, so where we are now, and then the recovery period, what happens afterwards. It's that recovery period that's the most important in terms of determining mental health outcomes. So what we need to do is make sure we do the recovery period really, really well, because that will both minimize the chance that people become ill, and it will maximize the chance that actually they will experience what's called post-traumatic growth, which is this idea that anything that doesn't kill you makes you stronger. And now I'm absolutely confident we're measuring this, we don't have the data yet, that there are many staff out there who will have done fantastically during this pandemic, and they will come out of this thinking, do you know what, if I can cope with a year of that, there's very little I can't cope with, and they're going to be absolutely right. So we need to give people a proper thank you. We need to, not just say, dear Neil, thank you for your work. We need to say, dear Neil, thank you for working on Maples ward and the staff working on these shifts. We need to make it personalised and say a proper thank you. Give people information about the help that you might have available for them. Don't just send them straight back to work. I know everyone's really keen on recovering our services to get their hip operations done again, but the phrase here has to be, we need to recover our people before we recover our services. If we don't recover our people properly, we're going to have longer term problems. Really important that everyone who comes back to work has a return to work interview, which I know sounds crazy because we've been working really hard, but a return to more normal work. We need to find out what was their experience during COVID. Have they got these moral dilemmas that are sitting there? Also, what's gone on at home? Have they had a bereavement? Have they had financial difficulties? Has a partner lost a job? Have there been illnesses? Because unless we know what someone's situation is, we can't put in place a plan to optimize their recovery. So it's really important that these supervisors who feel confident to have these wellbeing conversations have a discussion with people in the first few weeks, first few months, about how are you, what's your experience, what can we do to make the next period of your work better. And then we need some time for reflection and meaning making, because we come back to that moral injury. How do we make sense of these really difficult experiences? And what we think works best here is to have a meaningful leader-led open discussion, not about necessarily what went on, who did right and who did wrong, but about what was the impact, what were the situations that really impacts upon you. And this ideally starts off with a leader saying, let me start off by saying, I have not got this right. I've had lots of real struggles myself about what the right things have been. And to set out that open discussion so that actually what everyone can come to is what we call a meaningful narrative, which is a story that doesn't end up with, it's all my fault, I did terrible things, or it's all my boss's fault, I was let down. But a story which says, you know, we were not always in the same boat, but we were in the same storm. And actually we can come to an understanding that not everything was right all the time, but actually we did an awful lot of good out there, and we did our best in really challenging circumstances. And whatever model you decide to use, you might have heard of Schwartz round or one way that this is done. You know, you want to talk about the facts, the impact of this, how people are now, and then some education about how we are in this together. And the aim is to reduce the stress that people are feeling and to improve working relationships. So there should be reflective practice that should be going on, particularly as people begin to try and make sense of things. And then to kind of finish up with the recovery, the rebuilding bit, is active monitoring, keeping an eye on people. People will not necessarily present with problems on day 2 when they come back to a more normal way of working. These things will sometimes take quite a long time to come out of the woodwork. And then when people do become unwell, or if you identify them as unwell, they should have timely access to evidence-based care. They shouldn't be put on a waiting list or put in a sort of holding group. And that care should be occupationally focused. It should have return to work as a key outcome. The evidence is that if you make return to work as a key outcome of your treatment, you're much more likely to get people back to work. That's good for them, and it's obviously good for the health service as well. So the conclusion of my talk is, do not over-medicalize normal distress. Many people are distressed. Have a nip it in the bud approach. Try and get in there early when the solutions are easy. The team holds most of the answers for psychological support. Try and build in collegial support. Make sure your supervisors critically feel confident to have these well-being conversations, and make sure that they're doing them regularly as the shifts go on, but also when people are coming back to more normal work. Don't forget those PIES principles. They're really helpful. Keep give a thank you, bit of chance to get back to normality or to recover before you go back into normal work, and some time for reflection. What does this all mean? And keep an eye on people and get them to the right sort of care. That's me. If any of you do Twitter, that's my Twitter handle. I try and pump all my the papers come out on Twitter. And other than that, I will stop my screen and happily take any questions.
Thank you for that, Professor Greenberg. That was incredible. I'm taking notes. I can't keep up with you here. Learned so much. Psychological debriefing. This is news to me. Do not do it. Amazing. But the practical solutions as well that you outline, that we, you know, colleagues helping each other, good supervision, and certainly the aftermath of this. We're moving towards hope, and it is important that we keep up the good work and we understand what we need to do next. There are questions. We have a couple of minutes for questions. We've got 3 minutes. There's some questions in the chat, the questions and answers box here. So I'm just going to take them as they have come in. The first one is from Jonathan Egan. Could the moral injury aspect be related to health staff who already have their own complex trauma?
So absolutely. So when you're trying to make decisions about these really difficult situations, the decisions you make and your belief patterns are going to be built up upon your experiences that you've had to date. So there may well be people who believe that actually, you know, these sort of situations should not happen. We should never be put into a situation. You know, the classic one was with PPE early on. So it's quite right to think we should never have been put in a situation where we were asked to deal with patients where we didn't have the right PPE. And of course, that belief's absolutely right. But then from a bigger point of view, assuming you didn't go into the situation, so the patients died, but you were safe, how does that sit with your moral or ethical code? In the UK, we had the Manchester Arena attack a couple of years ago now, and what's happened recently has been a big inquiry. The firefighters there weren't allowed to go to the Manchester Arena after the explosions because there was thought there was more terrorist activity. So they were put into a car park some miles away in a holding pattern, waiting to go in. They never went in for 2 or 3 hours afterwards. Now, they were completely safe. That was the right thing from a terrorist point of view. Those firefighters have been racked with guilt about not going to save the public that they wanted to save. What was the right situation? There is no right answer. And so this point about moral injury here is it's coming to an understanding, even if it's a slightly depressing understanding, that actually we did our best in difficult circumstances. And it's very easy now to say you should have done A or B, but at the time you were doing your best.
Yeah, absolutely. Thank you. From Hazel Smith, thank you, Professor Greenberg, for your presentation. For the PTSD rates for NHS staff overall and ICU in particular, you presented data on nurses. Can I ask if data on midwives was collected? They are being redeployed to, and their clinical background is pregnant women and neonates, not adults. And pediatric ICU nurses being redeployed to adult ICUs, or when PICUs are partially or fully transferred to adult ICU.
So we do have data on all clinical staff actually in our NHS check study. We haven't looked at them by particular speciality so far. I would have no doubt at all that if midwives and paediatric intensive care staff were redeployed into ICU settings, they are going to be at increased risk. That ICU data that I presented in particular, we've now done 6 surveys. I was presenting there the first 2. In the last survey, which we did last month, so right in the middle of our third wave, our third peak, what we found there is actually it was the staff who are usually on the ICUs actually appear to be more distressed. And we think the reason for that is the people who have been redeployed tend to get redeployed for a few months at a time, and then they go back to whatever normality is. Whereas the ICU staff who are there at the moment have been working, as we all know, with really challenging situations for a year or more now. So I think that anybody who's redeployed is at risk, but you need to look about how long they were redeployed for, and of course what the expectations were on them. Now, imagine if you're a paediatric intensive care, the expectation might be you should just do what you do normally, but for adults. And that might be far more challenging than perhaps being, as I say, a surgical outpatient nurse, where you're never going to be at, within 2 months at the same level as someone who might normally work there.
Yeah. We have about 3 more questions, but we're running out of time. I'll take one from John Gilmore, and then Neil, I might send the others to you after the symposium, just because we do want to keep to time. From John, thanks for the presentation, Professor Greenberg. I'm just wondering how much issues such as incivility and hostility within the workplace may impact on rates and responses to moral injury and PTSD. These issues are very prevalent, particularly in nursing.
Yeah, no, absolutely. So the hostility piece is I think is really important, and that's sort of come out a lot, a bit with the sort of comments that are sometimes made on Twitter, which are completely unpleasant and unwarranted as well. The evidence is that if you feel that you have been doing your best, and then what you get instead of thanks in response is people being hostile to you, that has the potential to be this third arm of the moral injury, is betrayal by people that you should have who you should have known better, who you thought that you could trust. So there definitely is a potential for that. I guess the positive side there is the question is, what could you as an employer do about it? Is actually the world is full of, thankfully, a minority of idiots anyway. We've known for years, way before COVID, there were plenty of people out there with some views and attitudes that have just never been right. And so the more that we can place them in the irrelevant category rather than the important category, that's likely to be helpful. And that's not just going to be what you think, that's going to be done by your managers. And the stuff that certainly came out with hospitals that are apparently empty, but there's people taking pictures of empty wards. That was frankly ridiculous. And I know it can upset people, but actually really we need to see these people as being idiots and just irrelevant, I think.
Yeah, absolutely. I just want to remind people that there is a break in an hour. Also, Neil, you can respond to any of the questions if you like in the chat box there.